Okay, so I'm Rana. I'm one of the anesthesia residents. I'm here this month for my cardiac block, my first block of cardiac. So I thought I would present on something cardiac related, and then I started looking into pulmonary hypertension and cardiac surgery, and most of the interesting evidence and treatment came from patients with end-stage heart failure and heart transplant. So I initially started on that, and then I know there are no heart transplants here, and I wanted to include something that could be applicable to everybody. So this is a bit different than what was advertised in the email, so I'm sorry, but I'm going to talk a bit about pulmonary hypertension and all kinds of surgery, and then touch on cardiac transplantation just a little bit. I think my mic should be on for Eagle Ridge, so I'm not sure if anybody's there. So it won't matter. I'm just going to quickly define pulmonary hypertension, mainly using the hemodynamic classification. In addition to the WHO classifications, talk a little bit about initial TTE for diagnosis, and a little bit about the right heart cath. I'll talk about the physiology of right ventricular ischemia and failure, and then just talk a little bit about perioperative management in non-cardiac and cardiac surgery, and a little bit about how they manage end-stage heart failure patients with pulmonary hypertension prior to heart transplant. So what is pH? It's defined as an elevated mean pulmonary arterial pressure of equal to or greater than 25 millimeters of mercury at rest, and I think you can go up to 30 on exertion. And it's either from a primary elevation in the arterial system, which we'll see later on, also known as precapillary pH or pulmonary arterial hypertension, or it can be from elevations in the pulmonary venous system or postcapillary pH. And the upper limit of normal for mean PA pressure, as we all know, is around 20, and sort of the gray area between 21 and 24. Most clinicians seem to think that it's sort of borderline and of uncertain clinical significance. So this is the WHO classification that we're all familiar with. Previously, Group 1 pulmonary arterial hypertension was classified as primary pH, as in having no identifiable cause, whereas everything else was identified as secondary pH. So now Group 1 has been separated from everything else, mainly because the pathophysiology, the natural history, and the response to treatment is quite distinct from the other types. Mostly we'll be I won't really be talking about groups 3 to 5. I think in terms of the hemodynamic classifications, I'll be talking about groups 1 and 2 just to highlight what the differences are. Again, this is just repetitive, a little bit of detail about the different things that could contribute to group 1 or group 2 pH. So just to help me get my point across in terms of the hemodynamic definitions, I'm going to quickly touch on the pathophysiology of each of groups 1 and 2. So group 1 is basically a proliferative vasculopathy, so it's characterized by intimal fibrosis, hyperplasia of the media, adventitial proliferation, and it mainly causes changes in the precapillary pulmonary arterioles. And you have an imbalance of vasoactive hormones that basically favor vasoconstriction and cell proliferation. So the levels of arachidonic acid metabolites are skewed away from prostacyclin, which is a potent vasodilator, inhibits platelet aggregation, has anti-proliferative effects on smooth muscle, and it skews towards thromboxane, which does the opposite. You have diminished production of nitric oxide, which is also a potent vasodilator, and elevated levels of endothelin-1, which causes vasoconstriction. And it's actually been shown in patients with pulmonary arterial hypertension that they have some defects in the storage and transport of serotonin. So they have elevated serotonin levels in their plasma, and that also acts as a smooth muscle cell proliferator and a vasoconstrictor. In contrast to that, again, as we all know, pH from left-sided heart disease starts with some sort of cardiac lesion that increases your left atrial pressure. And mitral valve disease was traditionally the leading cause of pulmonary hypertension from left-sided heart failure, but that's more recently been replaced by heart failure, whether it's systolic or diastolic, as the leading cause. And basically that increase in left atrial pressure causes retrograde pressure transmission into the pulmonary venous system, or post-capillary pulmonary hypertension. Now, in most patients, that increase in pulmonary venous pressures are passive, such that with underlying treatment of your left heart disease, you can get reversal of those changes. But as your disease starts to progress, your transpulmonary gradient, which is defined as the mean pulmonary arterial pressure minus your left atrial pressure, which is normal in purely post-capillary pH or less than 10, starts to rise. And at that point, you start to develop some irreversible features of pulmonary hypertension. So your transpulmonary gradient rises and your pulmonary vascular resistance rises as well. And when they look at these patients, histologically, the patients with group 2 pH that have developed irreversibility, they sort of resemble they histopathologically resemble pulmonary arterial hypertension. And so at that point, they're less likely to improve with medical management. So I'll talk a little bit about the initial screening or initial workup with a transthoracic echo. But the gold standard for a right heart for diagnosis is a right heart cath, especially before the start of treatment for suspected group 1 pH. And the hemodynamic parameters really help highlight the difference between pre and post-capillary pH. And in addition to that, it'll help distinguish patients with group 2 pH who have purely pre-capillary changes versus those that have developed irreversible changes or a mixed pre and post-capillary pH. Sorry, I said that backwards. Patients who have purely post-capillary versus those who have a combined post and pre-capillary pH. So in patients with group 1 pH, their pulmonary wedge pressures are low or less than 15 because they don't have elevated left-sided pressures. And that distinguishes them from group 2 pH, where you have elevated capillary wedge pressures. And they define that here as greater than 15. And patients, as I just talked about earlier, in group 2 pH who have purely post-capillary pH have a low PVR. I think the normal PVR is around 1 Wood units, and so they define low as less than 3. And they have a normal transpulmonary gradient. Whereas patients that have started to develop a mixed picture might have an increased PVR or greater than 3 Wood units, and they will also have an elevated transpulmonary gradient. And this table is from UpToDate. And again, you can see that patients with group 1 pH, so everybody who's got pulmonary hypertension, has elevated mean pressures of greater than or equal to 25, but those with only group 1 or pre-capillary pH have normal wedge pressures, and those with group 2 pH have elevated wedge pressures. And in the bottom 2 rows, that's separated into purely post and combined, and you can see that in the former you have low transpulmonary gradient, or here they've mentioned a diastolic pulmonary gradient, and a low PVR, whereas in the mixed picture you have elevated levels of both, or elevated values. These tables in the next two slides are from the combined task force for diagnosis and treatment of pulmonary hypertension from the European Society of Cardiology and the European Respiratory Society. And I just wanted to include this because in their previous guidelines from 2009, basically they suggest using the tricuspid regurg velocity as well as estimations of the PA systolic pressure to initially, when working up a patient with potential pulmonary hypertension, to classify them as having either unlikely, possible, or likely pH to guide further workup or intervention. Whereas in their most recent guidelines in 2015, they mainly use the tricuspid pulmonary, or the tricuspid regurg velocity and not the PA systolic pressure. And so the reason for that is so you can estimate PA systolic pressures based on the modified or simplified Bernoulli equation if you measure the tricuspid regurg velocity as well as the right atrial pressure. And the right atrial pressures were estimated based on the size and respiratory variations and diameters of the and flow in the IVC. And they mentioned that there can be a lot of inaccuracies when doing that and estimating right atrial pressure. And so they've decided to take that out and instead just look at the tricuspid regurg velocity at its peak, in addition to extra features that could indicate pulmonary hypertension, such as changes on your right side of your heart in terms of volume and pressure, changes in your intraventricular septum, like flattening or bowing towards the left, looking at some of the pulmonary regurg velocities, and then in addition to that, also looking at the distensibility or diameter of the IVC. And they do recognize that the tricuspid regurg can be underestimated or overestimated as well. So if, for example, in patients with severe TR, that regurg velocity at its peak could be significantly underestimated. But this is sort of only a guide to try and determine as an initial step how likely it is that the patient has PH and to guide further intervention or further workup. So why do we care about all this? So in terms of non-cardiac surgery, currently PH, I don't think in the AHA or ACC practice guidelines for non-cardiac surgery is listed as an independent risk factor for postoperative complications. But there have been some studies, and it is a bit limited because they're mostly based on small series, and so it still remains poorly defined, but there have been some studies that indicate certain risk factors in patients with pulmonary hypertension that could predict perioperative morbidity and mortality, and those can be related to intra-op or post-op hemodynamic instability, heart failure, especially right-sided heart failure, dysrhythmias, increased length of hospital stay, etc. And what all those studies that are listed there, they are a little bit older, but they together they sort of, these risk factors have been put together from all of those different studies as potential predictors of increased risk in patients undergoing non-cardiac surgery with pulmonary hypertension. Some of them are pretty self-explanatory. So those who've got, other comorbidities, their functional, their New York Heart Association functional class is at a higher level, meaning they have more symptoms. Their ECG changes that can point to right-sided changes as a result of pulmonary hypertension, elevated pressures, etc. And then they also talk about immediate or high-risk surgery, emergency surgery, and longer surgeries being a higher risk. But I'm sure that's not only for patients with pulmonary hypertension. This study specifically looked at about 3,500 patients retrospectively. This was in anesthesia and analgesia in 2010. And they looked at patients with a diagnosis of PH undergoing either a total hip or a total knee arthroplasty. And they found that there was a 4 to 4.5 fold increase in the mortality rate in patients with pulmonary hypertension And in the subgroup that had group 1 pulmonary hypertension experienced the highest mortality rate. Now, I looked through the paper and I tried to find what their definition of pulmonary hypertension was, and I actually couldn't. It sounds like when they looked at the databases, they used pulmonary hypertension if the patient had a diagnosis of pulmonary hypertension. So unless I missed it, I couldn't find a certain number that they used, which could affect things a little bit. In terms of cardiac surgery, the negative impact of pH is a bit more well known, and there have been mortality rates up to 25% that have been quoted. And again, there are a few different reasons why, or different causes that can result in this perioperative morbidity and mortality, but the risk of RV ischemia and dysfunction seems to be a significant factor, especially when coming off cardiopulmonary bypass. Some of the risk factors from the studies are listed down below. Just the first 3 lines, I guess, are talking about cardiac surgery, non-cardiac transplant cardiac surgery. And they did talk about that second line where it talks about the mean, that's actually mean systemic blood pressure over mean PA pressure ratio of less than 4 as being an increased risk. And their rationale for that was after inducing a general anesthetic, both the absolute values of the systemic blood pressure and the PA pressures will both drop. But they sort of looked at 1,500 patients in one of their studies and found that those values, even though the absolute numbers both dropped, that the ratio remained the same. And they found that that ratio seemed to be a good estimate of the severity of pulmonary hypertension, and it seemed to behave similarly to other hemodynamic parameters in terms of predicting hemodynamic complications after surgery. So things like requirement for intra-aortic balloon pumps or vasoactive support for over 24 hours, post-op death, etc. And they found that a ratio of less than 4 was at increased risk. And so their rationale was that in patients who are awake, sure, you can use the absolute numbers, but in those under a general anesthetic, the absolute number might be underestimating their pulmonary hypertension, and that the ratio seemed more appropriate. And there does seem to be growing evidence that the perioperative morbidity that's associated with pulmonary hypertension cardiac surgery may not necessarily be as a result of the absolute value of the pulmonary pressures, but rather sort of how the RV has adapted and what the state of the right ventricle is. So why is pulmonary hypertension, I guess, a concern in the perioperative period? Basically the main concern is acute right-sided heart failure and hemodynamic collapse at its most extreme. And there are a lot of different factors, both in the non-cardiac surgery periop period as well as cardiac surgery, that can contribute to worsening of your pulmonary pressures and right-sided dysfunction. So as we all know, you can get acute rises in your PVR with hypoxia, hypercarbia, acidosis, hypothermia, any sort of sympathetic stimulation like pain or airway instrumentation, super high levels of PEEP, and then again in the perioperative period, the positive pressure ventilation can cause reduction of your preload to the right side and reduce your cardiac output, which can further worsen RV ischemia. In certain surgeries with with lots of fluid shifts and high requirement for intraoperative volume, overload becomes a problem, and because of interventricular dependence, which I'll quickly touch on, it can cause reductions in your left-sided output as well, and further lead to hypotension and RV ischemia. These patients are already predisposed to dysrhythmias, especially atrial fibrillation from their atrial dilation, and so the risk of perioperative arrhythmias are higher. And then any sort of event in the perioperative period, like a pulmonary embolus, which is a risk for anybody undergoing surgery, but that can cause acute worsening. And then in addition to all that, with cardiac surgery, with the effects of cardiopulmonary bypass, you've got increased, atelectasis, ischemia, reperfusion injury, a bunch of inflammatory mediators that can cause capillary permeability and increases in your PVR, and left-sided ventricular dysfunction post-bypass, leading to elevated pressures and increased left atrial pressure, and RV failure after coming off pump as well. So, and then in cardiac surgery specifically, in addition to sort of what we talked about, there are a few other reasons why patients can have pulmonary hypertension or worsening of their pulmonary hypertension in cardiac surgery. So, like I mentioned already, they could already have pre-operative LV dysfunction, whether it's from valvular disease, from heart failure, secondary to non-valvular disease, like ischemic. You can get ventricular dysfunction post-bypass. And we talked about sort of the inflammatory mediators. There are 3 different types of protamine reactions that you can get, types 1, 2, and 3, with the most extreme and the most rare being a type 3, where you can get severe increases in your pulmonary vascular resistance. And I believe that's caused by the large sort of heparin protamine molecules being lodged in the pulmonary circulation. And then you can, with valve surgeries, you can have this thing called patient prosthesis mismatch. So, for example, in mitral valve replacements, if your effective orifice area is small in relation to the size of your body or the size of the patient's body, you can generate higher pressures across that valve despite a normal functioning prosthesis, and that causes pulmonary hypertension to persist and result in continued sort of pressure on the right side of the heart. And then we already talked about intraoperative or perioperative hypoxemia, hypercarbia, etc. So I'll just touch on this quickly because I feel like I'm repeating myself a little bit, but in terms of RV anatomy and physiology, we all know that the RV is, it's thin, it's crescent-shaped in cross-section, it's sort of the intraventricular septum position bulges into the RV because of higher LV end systolic pressures than RV end systolic pressures. The idea of ventricular interdependence is basically that force is transmitted from one ventricle to the other through the myocardium and the pericardium, and that helps maintain the position of the intraventricular septum. And the 2 ventricles are actually dependent on each other to a certain degree for their cardiac output. And the right side is more dependent on the LV than the LV is on the right side, but basically 20 to 40% of the cardiac output of the right ventricle depends on the LV. And in contrast to the left ventricle, where perfusion to the coronaries is mainly diastolic because of the pressure gradients between the systemic and the right side of the heart. Perfusion occurs both in systole and in diastole. So initially, when your RV pressures rise, your coronary flow in systole is affected, but as your disease progresses and you get rises in your left ventricular pressures or decreased left-sided output because of intraventricular dependence and right-sided heart disease, and your diastolic pressure or cardiac output as a whole drops, and you get further reduction in your perfusion from a diastolic perspective, which can lead to ischemia. So this is basically saying the same thing. So when the RV is facing increased afterloads to try and avoid an increase in wall stress, it hypertrophies, and eventually, for some reasons that are unknown, that hypertrophy turns into dilation and allows the cardiac output to be maintained by allowing more volume or allowing the heart to maintain preload. but eventually that sort of increases your wall stress and your oxygen consumption. You get heart failure and increased pressures, leading to tricuspid regurg, etc., and left-sided failure, as we talked about. And I won't belabor this point anymore because I think we've talked about it enough, but basically these are just diagrams of the of how dangerous right-sided ischemia and failure can be. In terms of treatment for pulmonary hypertension perioperatively, so obviously you have preoperative treatment, whether it's primary or secondary. So primary treatment would be targeted at the underlying cause, for example, in left-sided heart failure, fluid management, beta blockade, LV enhancement therapy, etc. And pulmonary arterial hypertension doesn't really benefit too much from primary treatment, and so a lot of the pharmacologic agents that are known are targeted towards pulmonary arterial hypertension. And I won't go into detail in all of them because I don't think we'll have time, but basically vasodilating medications such as calcium channel blockers in those who have vasoreactivity after vasodilator testing. You have your endothelin receptor antagonists, your phosphodiesterase 5 inhibitors, your prostacyclin analogs, and there are different intravenous and inhaled forms of those. And this table just shows sort of one guideline in terms of how patients are started and maintained on these medications depending on their functional class. And the WHO functional class of pulmonary hypertension is pretty similar to the NYHA class from 1 to 4 depending on what their symptoms are. In terms of these medications used for patients with group 2 PH, there really isn't any sort of good evidence, and it does require further investigations. There have been some studies using these medications in patients with heart failure. There have been previous studies with epoprostenol that in patients with heart failure that ended early because of increased mortality. There was studies with bosentan in patients with heart failure that showed to increase the risk of worsening heart failure and cause transaminitis. And the one drug that was shown to improve hemodynamics and exercise tolerance was sildenafil, and that's actually used in the perioperative period in patients that are awaiting heart transplant, as we'll talk about. But mainly these therapies for this group are basically guided towards improving the underlying disease. I've sort of touched on this a little bit. We've kind of touched on some of the anesthetic considerations while talking about other things, but another one is potential for right to left shunting if there's a PFO that can lead to hypoxia and paradoxical emboli intraoperatively, and that hypoxia can worsen your PVR and sort of cause a dangerous cycle there. There are a lot of guidelines in terms of perioperative goals for patients with pulmonary hypertension. This is mainly for non-cardiac surgery from the CHEST guidelines, and they're all pretty self-explanatory. Preoperatively make sure that the patients remain on their pulmonary hypertension medications, optimize their fluid status, etc. And patients with left-sided heart disease, as we talked about, avoid sympathetic stimulation or try to mitigate them. Use of invasive monitors, lung protective ventilation, etc. And again, because we don't have time, I won't go through the details of all these different drugs because probably respirologists might care about that more. But these are, again, there are IV and inhaled forms that are used perioperatively or mainly intraoperatively, including sildenafil, epoprostenol, milrinone, dobutamine, whether they're vasodilators or inotropes for right-sided heart failure management, and then some of the inhaled ones as well. And I did come across a few, a lot of them are older, but there are a few studies that compare the use of inhaled vasodilators intraoperatively. These were mainly in patients presenting for cardiac surgery versus IV vasodilators, and the sort of the drawback using IV vasodilators is a systemic effect, so there's really nothing that only acts on the pulmonary vasculature and doesn't cause reductions in your systemic vascular resistance. So that's what mainly limits the use of the IV agents in the perioperative period. And there are some studies that have shown that you can get improvement in your hemodynamic parameters with these inhaled agents without or reducing the need for vasoactive drugs intraoperatively or perioperatively because you're avoiding the systemic effects. I personally haven't managed pulmonary hypertension with these medications in cases, and having just started cardiac surgery, I haven't really seen that much. So, but from what I've seen, usually is a mix of. Usually, I've seen inhaled and IV, mainly milrinone or things like Flolan or inhaled nitric oxide. And one option is to counteract the systemic effects of the IV vasodilators with vasopressors. Is usually what I've seen as well. So there's no hard guidelines, but some of the studies did find that the inhaled ones alone worked well. And there was also some evidence that prior to bypass in patients with pulmonary hypertension, treatment with inhaled milrinone would reduce PA pressures post-bypass compared to patients that were not treated with inhaled milrinone. And then in terms of management of acute RV in the operating room, for example, when coming off pump, usually if there's no evidence of right ventricular outflow tract obstruction, the dysfunction can be either classified as an ischemic cause or a non-ischemic cause. So if ischemia is suspected, then the management is geared towards improving RV perfusion, both medically as well as surgically, like with RV assist devices, etc. And non-ischemic cause, again, would gear you towards medical management. When you read about pulmonary hypertension and heart transplant, there's a lot of mention and cardiac surgery. A lot of the evidence, or there's a lot of talk about pulmonary hypertension and heart transplant recipients. And so I thought I would talk about that just briefly. But about 72% of patients with end-stage heart failure have pulmonary hypertension. And it is a very well-known independent risk factor for mortality, both early and late after heart transplant. Again, the main concern is the high risk of RV ischemia and failure in the perioperative period. And the actual degree of what sort of level of pulmonary hypertension precludes cardiac transplant is controversial because there's sort of a continuum, but basically it's decided upon that patients with a PVR of greater than 2.5 and a transpulmonary gradient of greater than 12 are considered to have significant PH, meaning that they have a known increased risk of early post-transplant death. And currently the CCS guidelines have cutoffs for contraindications to cardiac transplant. So patients with PA pressures greater than 50, systolic, a PVR greater than 4, and a transpulmonary gradient greater than 15 after being challenged with vasodilators like milrinone nitric oxide, etc., are considered to be a contraindication for cardiac surgery. A lot of these studies were so old that the online versions weren't even available, but that's kind of what's agreed upon right now. And so these guidelines are from the International Society for Heart-Lung Transplant. And it basically outlines what to do with a patient with end-stage heart failure awaiting heart transplant. And so obviously everybody gets a right heart cath, and if their hemodynamic parameters or PVR, et cetera, below a certain level, then they might get a repeat heart cath annually while they're waiting for their heart transplant to make sure that their PA pressures haven't gone up. And in patients that are found to have elevated PVRs, they will be challenged with vasodilator testing to determine if their pulmonary hypertension is reversible or not, so i.e. whether there's a precapillary component or not. And so anyone with a PA systolic pressure over 50, a gradient of over 15, or a PVR greater than 3 would get this vasodilator challenge. And if their vasodilator testing sort of fails to achieve this reversibility, then they might actually be admitted to hospital and treated with, days or several weeks of vasodilators like milrinone or sildenafil to try and bring down their pulmonary pressures. And if that fails, there is some evidence that mechanical assist devices also have the ability to reverse pulmonary hypertension in preparation for heart surgery or heart transplant. I won't go through this in detail because I think we're starting to run out of time, but basically this study, all the studies prior to this on sildenafil and pulmonary hypertension and end-stage heart failure had showed benefit of just a one-time administration, and this was the first study that showed that several weeks, here they used 12 weeks in particular, significantly reduced both the pulmonary vascular resistance and their PVR to SVR ratio after a prolonged period of time. So that kind of gave hope to patients with initially what was thought to be irreversible pulmonary hypertension. And in terms of mechanical assist devices, there's a question of, well, how long do you allow somebody to have an LVAD, for example, and how long do you allow them to try and reduce their pulmonary pressures? And there are a few studies that have been done. Again, most of them are a bit older, but this one in particular kind of looked at 145 patients over about a 10-year period, and they separated them into patients with fixed pulmonary hypertension that was defined as a mean pressure of over 25 and a PVR of over 2.5, and an elevated transpulmonary gradient despite pharmacologic therapy, and they separated that from patients with irreversible or reversible pulmonary hypertension. And they split them into groups of having an LVAD for less than 6 months, 6 to 12 months, and greater than 12 months. Sorry, I'm changing the slides on my computer. I apologize. Basically what they found was patients with an LVAD had significant reductions in their mean pressures and their pulmonary vascular resistance in all groups, but there was no significant difference between the groups. And so they concluded that if 6 months is a good time to have your reversibility or have a chance for your pulmonary pressures to reverse, and any time after that was of no additional benefit. Yeah, this was just interesting to me because I saw this in a few patients during my heart failure rotation last week, where they have super high pulmonary pressures and they're in hospital for several weeks on IV milrinone and sildenafil and then move on to having ventricular assist devices, and then move on to having a heart transplant. So it was just interesting. Yeah, so that's it. Yes.
So you mentioned about the TR jet determining pulmonary pressure. How does the function of the RV, as we usually measure it through TAPSE, work into that equation? In other words, if your RV is crappy and doesn't really work very well, can you still rely on the TR jet to determine your pulmonary pressure?
No, I don't think you can. Yeah, so there are definitely, I guess, issues with just looking at the TR jet. And I think reductions in your TAPSE, I'm not an echo expert by any means, so I don't know if I can explain it in detail, because I don't think I know the answer very well, but my understanding is that if you have reduced RV function, that could underestimate your TR jet velocities and underestimate your level of pulmonary hypertension. That's my understanding. Is that right?
For those of us who are kind of just looking for numbers, you know, the thing about pulmonary hypertension that has always confused me is you get these position statements and they're 18 pages long, and I'm not really quite sure how to apply that to my practice, because I'm not going to put them in the hospital for weeks of milrinone to see whether their Woods units go down. Like, it's just not going to be what I do. So what number, Rana, like what are the numbers that you hang your hat on, that you look for in a patient's report of their right heart cath or their echo report to say this is mild, moderate, or severe pulmonary hypertension? And I'm asking because it just seems to be a bit nebulous, where we should have very clear numbers.
So my understanding is, I asked one of the respirologists this, actually, who specializes in pulmonary hypertension, and I was told that we always use the echocardiogram reports, and oftentimes they're reported as showing mild, moderate, or severe pulmonary hypertension, whereas the pressures that are reported on a transthoracic echo can't really tell us whether the patient has mild, moderate, or pulmonary hypertension, because they're all sort of probabilities.
So what numbers?
And so in terms of the systolic PA pressures, I've been told that anything over like up to 50 even is sort of where you say, okay, this patient could have some pulmonary hypertension on a transthoracic echo. But that's a good question. I don't know if there are certain numbers that I've read about that I just can't remember right now in terms of mild, moderate, severe. Yeah. Yeah, I think yeah, I don't know. I can answer that question for you in 5 minutes, but.
I've always thought of it as up to 25 is okay, and then up to 50 is, you know, concerning, and then over 50, I'll really watch that patient. I mean,
for mean pressures or systolic pressure?
Systolic pressures. Yeah. Doug, what's your?
Yeah, I think if it gets over 50, that would be a number in my head that catches my attention more. And then you see that, and then exponentially increases from there, and you see the patient at 70, and that really gets your attention. But I think anything over 50, you're saying, yeah, a real issue.
So for us non-cardiac people, we do deal with a lot of pulmonary hypertension.
usually after the fact.
Yeah, but we'll get an echo report, you know, showing a systolic pressure that's 50, 70. It's really unusual that any of these patients have had a right cath report. And so are you saying that really, if we see these people perioperatively, we should be sending them you know, if their echo is showing 50, they should all be sent for right heart cath. They should be sent to the, I mean, I've tried to send patients to the pulmonary hypertension clinic at VGH. It's a very slow process.
Yeah. So the guidelines recommend, so initially patients would start off with a transthoracic echo, and if you find features on the echo that could explain that PA pressure, like if they've got significant left-sided heart disease, or if they have a history of, you know, severe COPD, let's say, something that could explain that level of pulmonary hypertension, that they don't necessarily need to get a right heart cath. It's sort of the right heart cath, as from my understanding, comes in after all the other workup has been done in terms of determining whether group 1 pulmonary hypertension could be playing a role, or if there's any plans to start therapy for the pulmonary hypertension, is my understanding.
Caths aren't innocuous for this population either.
Yeah. But often there's no explanation for it. No one really, even when you send them to the pulmonary hypertension clinic, they don't really do anything about it.
I think in our population it's more often that there is an explanation. They either have left-sided heart failure or respiratory disease or thromboembolism. Or sleep apnea.
Yeah.
And then we try and optimize those conditions. If they're under-optimized when we see them, say, in pre-admission, then we send them to, okay, well, clearly your COPD sucks, like go to your respirologist or your family doctor or whatever and like organize that. And then they still show up to the OR having been fully optimized from those chronic conditions.
With no change.
And they still have probably the same, my echo skills are definitely not able to pick up a TR jet and figure out how changed their
Oh, yes, they are.
pulmonary. I'm lucky to identify the tricuspid valve, to be honest. I'm totally honest. I would call a cardiac colleague, maybe, and be like, help me interpret this.
We will work on this.
But, yeah, so, and then I always feel like pulmonary hypertension is like, it's a bit like taking someone with severe uncorrected aortic stenosis to the OR. They're at high risk. We do everything we can. Most of the things you would do, short of using the nitric oxide and other IV agents, are sort of like, I call them like the motherhood anesthesia things, right? You're going to avoid pain, you're going to avoid sympathetic stimulation, avoid hypothermia, avoid hypoxia, avoid anything that will make the RV have to work harder. And then you tell the patients and the surgeon the risks, and then proceed. Do other people have other... That's sort of my approach. I don't know if that's right or not. From your talk, it sounds like we're sort of on the right track.
So,
I don't know.
so I actually should ask a few cardiac people. There must be a couple of them in here somewhere or other.
You're staring at them.
No, I know there's two. I was wondering if there were more. No,
Not enough.
Okay. No, that's cool. I know when I was doing cardiac and I ran into this, the one thing I always found was phenylephrine was an absolutely bad drug. Like, for whatever reason, it would almost always cause PA pressures to skyrocket. So I'm talking non-cardiac surgery. That's one of those cases where you would think that if you actually have to support pressure, norepinephrine is a better drug. Have you guys noticed that? Have you ever tried that?
No, I have not found that. I think that there's, beyond motherhood statements, there are certain interventions that you can do that are very helpful with pulmonary pressures. And phenylephrine is actually not, in different analyses, looking at different factors, actually been a really big determiner of pulmonary pressures. May have been anecdotal for sure, but in terms of the big players, the issue is whether it's reversible or not. If you have fixed pulmonary hypertension that is utterly irreversible, no matter what you do, you're just gonna, like, that's gonna be bad. But there's certain things that we can do. The use of vasopressin is very helpful. The use of epinephrine to help the RV is also very helpful. 5 milligrams of inhaled milrinone is lovely. John was a big user of milrinone when you were doing cardiac, and I think that, you know, that half dose, that 2.5 milligrams, with the use of echo, watching that RV, if you're dealing with an RV in trouble, is very, very helpful. So there's different things, and you're absolutely right. I think this is one of those, we're doing more and more operations on patients that would normally be told no to 20 years ago. And I think this is where the Heart 3 position here is very, very helpful, to drop a probe and to watch an RV as you do these cases. And then it also expands the transesophageal echo skills of non-cardiac people in our department, because as an aside, I actually think that we should all be certified in basic transesophageal echo. And I think that's a doable skill in our department. So, I think there is certain things. There's Andre Deneau, who you did mention as one of your references, has an awesome review of pulmonary hypertension and perioperative. That's very readable. It does go through some very specific things that you can do some
How do you give inhaled milrinone?
You just do it through an aerosolizer.
So you just take the IV stuff and you aerosolize it?
Yeah, well, yeah, the IV stuff, and then you can shoot it down, or you can actually put it through that nebulizer. Yeah.
Coming off pump, just to, when you're doing cardiac? Just
That's a VGH.
That's totally a VGH.
Yeah.
So,
Doug, do you use it?
I mean, I think your point, the point that rang true for me is that a number of interventions you do reduce PVR. Most of those, all of those, if you give them intravenously, also reduce SVR. The problem with reduced SVR is then you're decreasing coronary perfusion of the right ventricle when it's already under strain. The other thing, as you mentioned, is the septum. That if you reduce SVR, the septum becomes flaccid, it changes its position. Your RV is dependent upon SVR maintaining that rigid septum, and it pulls against, it's a U-shaped thing that pulls against this rigid septum. So you take that rigid septum away by decreasing SVR, the RV loses about 30 or 40% of its effective power. So the patient then goes into RV failure. So I actually kind of agree that if your main issue is you've reduced SVR, if that's what's causing the swirling down, then you can use a number of agents to preferentially increase SVR. And I'm not afraid of phenylephrine in that case, or vasopressin if it's used in combination with something else. It's the yin and the yang kind of thing.
I think another thing that we probably underutilize is nitric, which is inhaled. It's an instant on and instant off. It is $1,000 an hour for nitric, and that has not changed no matter how many units you use. So it's like 20 parts per million, and it's kind of like vaso 0.04, like it's on or off, and it'll work or it won't work. It is something that we easily can call in from our team. We're happy to
So how would the mechanics of this work with Hearts 3? Can we book Hearts 3 for the procedure, or do we just sort of have this patient kind of show up on our slate and then scramble in the morning to try to track down Hearts 3?
It depends on the quality of wine you're offering.
Got it.
I think it is absolutely our job as Hearts 3 to do that. In terms of booking, like, I need you between 9:30 and 9:45. Like, I think that that's more difficult. It's kind of like Rover, when other things are coming in. But I think the awareness that this patient's coming in, that you want a chest wall echo before you go in while everything's getting set up for induction, that kind of stuff is very, very helpful. And I think it also expands the Hearts 3 position. And we've been called upon to actually participate in the residents' ultrasound rotation that's Doug's helping to bring in here, which is going to become a core rotation for chest wall echo for the residents. And that would be an awesome synergy.
So I can see that you guys are being pulled in many different directions.
That's what we're doing.
And, okay. Yeah, no, I appreciate where you're coming from, and just sort of looking at the things logistically and from a real world point of view, and we've got surgeons that want to get cases going. And
That being said, I've called on Heart 3 a number of times. I had a patient the other day, it just was super hypotensive, unexplainedly. It came up, it was fine, but I saw it like so useful to have a transesophageal echo here at some point, and every time I've asked, it's been no problem, and it might be a few minutes, but.
And Shelley and I saved a life last month.
It was, so it's really been, they'll come really quickly when you really want to see what that heart's doing, and I don't have the skills myself to do it, much like Susan. I'd love to learn, but much like Susan,
Well, there's just no time.
I don't have that skill.
But this is the way that we start that process. And I think it's actually, we're not just here to do the echoes and the pre-ops for hearts. I mean, you know, the way that we set up Hearts 3 was actually to have an outreach role for, you know, teaching and learning and being involved with non-cardiac patients. So I think it's awesome.
We'll just have to tell surgeons to chill until we.
And the one other point, or the one point that bothered me a bit in this presentation that to me doesn't ring quite through is the old echo may underestimate the degree of pulmonary hypertension, right? If you don't get a good envelope, all you're doing is guessing what that envelope, but if you got a good envelope and you can trace it and you know what the pressure gradient is across the tricuspid valve, that's pretty concrete, right? It's got to be at least that big a pressure gradient across the valve, and you can have arguments of CBP 5 or 20 to add to that number, but that number across the valve is mathematically correct, right? I mean, it's at least that.
Not greater. So I think both things are true. It can underestimate it if the RV is kind of.
If the impression I have of looking at it that way, if it's non-turbulent flow going through, so if you have massive regurgitation, then it's very hard to estimate the pressure gradient going across because it's not turbulent flow. But if you have if it's a small enough orifice, and therefore good envelope, and it's pretty good.
Thank you.
Thank you.
There's a sign-up sheet.